Welcome to this short presentation on local anesthetics in endodontics. I'm Lieutenant Max Butler. Thanks for joining us for this. Overall, what the goal is here is to spend about 20 minutes covering a few key points about using local anesthesia in our endodontic procedures. I'm going to go over what the different anesthetic options are and how to make a plan, how to follow that plan or why to follow that plan, and then a few other points to consider. Are different types of anesthetic. These are the main ones that you'll see in most clinics. You have lidocaine, articaine, bupivacaine, and carbocaine. Bonus to anyone who can recite all the colors for each of these. And the numbers that you're seeing here are a blend of really an average taken from Malamed's handbook on local anesthesia and Cohen's Pathways of the Pulp. It's about an average between those two of how long they last when used for local anesthesia, like local infiltration. Besides Marcaine, the numbers there are indicating how much extra time you get if you're using Marcaine for mandibular block, which is the main reason we use it. So let's just go through these briefly. Lidocaine is the main anesthetic used most of the time in dentistry. And it's also the safest for a pregnant patient. Plan on using it much of the time. It's a great anesthetic. And if you're talking about doing anything with your anesthesia, like buffering, it's probably best to use lidocaine because it's the most studied. Articaine or septicaine is double the concentration, same amount of epi, and it lasts longer and is more effective at infiltration than lidocaine in most cases. It's metabolized differently. It's an amide instead of an amine, and it has a higher success rate for local anesthesia as well. Bupivacaine or Marcaine is a lower concentration of the anesthetic and epinephrine, and its main indication is for lasting longer for blocks. Now, it doesn't last any longer for local. So don't try to do it for a maxillary molar that you want to stay numb longer to give local with bupivacaine. But for mandibular molars and premolars, it makes a big difference on how long the anesthesia lasts. Carbocaine plain is often what it's called, is 3% carbocaine with no epi, and it doesn't last as long. The epinephrine, that's the function of the epinephrine, to prolong the anesthesia, but you don't get any heart rate increase. It can be a good tool to have in your toolbox, and you should have it around. If you're going to do an intraosseous injection, it's the most recommended anesthetic for that, particularly because of the no cardiovascular effects that usually occur with epinephrine. Now, our different types of injections. We're going to start with just the mandibulars. The inferior alveolar nerve block is the main one that's used for mandibular posterior teeth. It statistically has an 80% success rate, which is not awesome, but it's the best we have in a lot of sense. Now, you need to keep an eye for a soft tissue sign like lip numbness. If you get a lip sign, it does not mean that they have pulpal anesthesia. If you do not get a lip sign, it's a pretty good indication that there won't be pulpal anesthesia. So if there's lip sign, it does mean you did not miss the block. If there's no lip sign, it's potential that you missed the block. But lip sign does not guarantee pulpal anesthesia. A cold test on the tooth you're about to work on is a really good idea to ensure that there is pulpal anesthesia. Start with just one carp for an IAN and then wait. It can take up to 15 minutes to hit. So just because they're still feeling the cold after 10 minutes, it doesn't mean you missed. And one of the studies in Cohen's book said you probably didn't miss. It may be some other sensitization things going on, and you should consider, rather than redoing the block, maybe consider a supplemental injection, especially if there's lip sign, because it means you hit it. Now this in yellow, slow is better, but not for irreversible patients. I want to go off on a little bit of a tangent here, okay? The way I put this presentation together, I read Cohen's Pathways of the Pulp, and I took notes on this chapter, and then I read the notes I had made from previous lectures on local anesthetic, and one of my notes said, slower is more successful. So I wrote that down and I stuck it in the presentation. Now, part of this presentation I sent to different people looking for feedback, and Lieutenant Commander Piono got back to me with some great feedback, and one of the things he mentioned was slower anesthesia is not always better, although or not always more successful, but it usually gives a better patient experience, and he cited a reference. And I went down a little bit of a rabbit hole, but it's a great lesson for all of us to learn. So briefly, we're going to go through this, okay? When he sent that back with a bunch of feedback, but this one specifically just because it's a good example, I thought I had this right. I took a note straight from the book. Is the book wrong? So I went back and I started to look into it. And I found the quote from the book. It says, a slow block increases success over a fast injection, but not for patients diagnosed with irreversible pulpitis. Now this reference is reference 204 from right here in the book. And it does talk about how slower was more successful. But I had to go into the reference itself to find the details. This study was done in 2006 with 38 healthy patients who were volunteers who had no tooth problems. They weren't in any pain. They were volunteering to get numb in the area, and they were measuring success by response to cold test. Now, reference 9 is actually the same reference that Lieutenant Commander Bono sent me. And that one is done in 2012, and it's done on symptomatic irreversible pulpitis patients. And it had, I think this one had 50 to 60 patients. And it said, its conclusion was that the slow block over a fast block made no difference in pulpal anesthesia, but it usually was less painful for the patients. So I want to show my progression of how I wanted to describe this piece of truth, or this insight. First, I was like, slow is better. And then I got more specific. What is slow doing? Slow injections are less painful and more successful. That's how I was defining it. And then I have to get really specific with these studies and what the textbook was saying. Slow nerve blocks, slow inferior alveolar nerve blocks are less painful and more successful. And now, after going through the different studies from the book and Lieutenant Commander Bono, slow inferior alveolar nerve blocks are less painful and more successful in asymptomatic patients, but don't have more success in regards to pulpal anesthesia in symptomatic irreversible pulpitis patients, according to a few small studies from over 10 years ago. There's probably been more recent studies going over this. The book just is old enough to not have them referenced, and I didn't take the time to do a literature search on all the statements from my notes. But I thought it was a really good example of what we can take something as truth, and often we simplify it and then we run with it. But it deserves scrutiny, and it deserves attention to details about what is actually being said and how that piece of truth was found and what the context of that study was. So I don't think all of us need to lose our minds about going down deep rabbit holes every time that we have to look into something. But know that you can look into things. You can learn it yourself. You don't have to be a mathematician or a statistician to figure it out. You can look at their literature, especially if it's something like a textbook or a CE course, they should have sources cited that you can look into and critically review for yourself. And you can do a search to find other sources that say other things. This is something I've been really interested in, how to make these decisions, how to make evidence-based decisions. And I've put together a couple resources that people can click into and use. I'll send it to the people who have joined the Endo Study Club, and you can click on it yourselves. But overall, it's the idea of start with what you know. It's probably not going to rock, whatever this piece of this information or evidence is, shouldn't rock your current understanding of things. See what other people are saying, your mentors, other dentists around you, teachers from school, if you have their lectures, or leaders in the dental field. What does the literature say? And leading organizations. You can go to AAE's website or ADA's website or AGD's website and see if they have any statements or advice on this specific issue. But you can also look at the literature yourself. Don't be afraid to open up PubMed or Google Scholar and ask some questions. It's not as hard as you think, and you don't have to open up every single study in the last 30 years and read them word for word. And then update your opinion. You don't have to spend 6 months' time researching this, and move on. If you're interested in it, dive deeper. If you're not, just update your opinion based on the basic review you did and move on. I enjoy it, and I think it's really valuable to understand how to do it. So going back, we're at our mandibular ejections. Slow can be more successful, but not for irreversible patients, for an inferior alveolar nerve block. But it is more tolerable by the patient. Okay, Gow Gates. People love saying, "Oh, you should try Gow Gates." It is a great injection. According to Cohen, it's not actually more successful alone in endodontics than the IAN, but it's a great combination to do with the IAN. An example would be you give a regular block an IAN, and they're not showing the lip sign that you want, or they're not showing good pulpal anesthesia. Go for a Gow Gates next, rather than repeat the same block that maybe something's weird with their anatomy and you didn't get right. The Echinosi block is good for people who can't open all the way, and it's relatively easy to learn. The long buckle is, you can use it as a supplemental for mandibular molars after the block. The mental is great for premolars. Don't kid yourself into thinking it's going to get like a mandibular central incisor, because it won't. But you can have like an 80% success rate for premolars, and it can last 30 minutes to an hour. Try to massage it in when you give it. The mylohyoid is another, I feel like it's a bit of a buzzword in anesthesia. Oh, they're not feeling the lip sign? They're not numb? Give them mylohyoid. I'm not saying that's wrong, but the studies from my review in the textbook mention that the mylohyoid doesn't really improve the success rate of pulpal anesthesia for mandibular molars. So it's not a waste of your time. You could think of it as, lingual side local, but don't go to that as a main effort every time. Local anesthesia, local infiltration can be used as a supplement for all the options, and it should be. Consider it much of the time. Intraosseous is more successful than just local infiltration or a PDL or intraligamentory injection for mandibulars. It's a little bit of a learning curve. You have to have specific equipment, and it can be painful for the patient. There can be post-op consequences. It can include a heart rate jump, which is why it's often recommended to use carbocaine. Once it becomes something you're comfortable with, it's a really good resource because it has a very high success rate. Sometimes some of the studies say if you give it twice, the success rate is as high as 100%. And then the IL, or it's used to be called the PDL. It's basically a type of IO. So you're not injecting through the PDL. You're entering into the PDL, but the anesthetic is traveling through the bone. And so in that sense, it's a type of IO. It's not damaging to the nerve, or it's most likely not damaging to the nerve, but there's a lot of back pressure going on, and just be careful with it. It can cause resorption at times or soft tissue damage. Okay, we're on to our maxillary blocks. I think we're doing okay on time right now. There's a few different kinds. You can get into a bunch of different techniques on how to do a PSA or an ASA or a greater palatine or a high tuberosity. I'm not going to go into those different methods right now and how to do them, but you should know some basics of them and be prepared to use them at times. You can do an intraosseous in the maxillary, and just you can do an interpulpal. That's good for maxillary or mandibular. I just didn't have room in the last slide. For an interpulpal, things to remember: you got to have back pressure. It's not necessarily about what the anesthetic is doing, because it's a pressure thing. Unlike the interosseous, where you need back pressure just to move it in, the interpulpal, the pressure is causing the anesthesia. It's very short acting, and you're committed to removing the pulp at that point. It's very painful, but sometimes this is just needed. Some teeth do not get numb no matter what you do, and this is what they need on access. So be prepared to use it. It's going to happen. Don't use an interpulpal on necrotic pulps. You're just pushing necrotic tissue around into through the apex of the tooth. This is a resource from retired Captain Alamang at the Endodontics short course in Bethesda, where he was talking about giving palatal anesthesia, and he gives great advice. You can read through that on your own. Overall, the idea is just go so slow. Several steps, very, very slow, and you can give what he calls a painless palatal injection. Now we're into the part of the presentation on making a plan. And I personally think everybody probably has done a mini version of this on their own. Maybe not written it out, but you've thought through, this is how I get this area numb in preparation for a root canal. I would encourage you to write it out. Make a legitimate plan. You don't even have to print it off or have it in your office if you don't want to, but I think it's valuable just for you to go through the exercise of writing it out. So briefly, I'll go through my plans, and if anyone would like, I can send this to you and you can modify it for yourself. These are evidence-based. None of this is anecdotal where I just think, this is what the resources say, but I'm experienced enough to know differently. I'm not kidding myself with that. I appreciate the work that others have done, and I recognize that I'm really new and learning in this field. So for mandibular posteriors, I'm going to start with an IAN, and I'm going to look for lip sign. I can expect this to last 1 to 2 hours. If I get a lip sign, I know I didn't miss, and I'm going to give local infiltration with articaine afterwards. If I didn't get a lip sign, I might have missed the block. I'm going to do a gout gates and then move on to looking for lip sign and local infiltration. Once I have the lip sign, I'm going to test with a cold test. I'm going to make sure that they have pulpal anesthesia. If they do, I'm good to start. I'll access, but I'll access slowly. And I'll keep an IO ready, and maybe I'll even use an IO before I access if I'm worried about them. Maybe they're a high anxiety patient or something else is telling me it may be difficult to keep them numb. If they're still feeling the cold test at this point, I'm going to give them an IO before I put the rubber dam on. Then I access, take it easy. If I get into the dentin and they're feeling it, give an IO. So remove the rubber dam or pull it off to the side and give the IO. If they feel it when I'm entering the chamber, I can either do an IO or consider an interpulpal at that point. And remember, for the IAN, consider Marcaine for long lasting, especially if I think they're going to have problems post-op recovering or increased pain for any reason. And then if it's a premolar, consider the mental block instead of the IAN. It has a good success rate. Just know that it's not super long acting. Okay, mandibular anteriors. This is where I'm going to give a local infiltration on both sides, buccal and lingual with articaine, and it's got a really high success rate. It's not going to last forever, but that should be what you need most of the time. You can give an IAN as well. It'll get to the mandibular anterior. It's not a bad idea. So same process. Give your anesthesia. Do a cold test before you start. Consider an IO if you need it. Don't really recommend a PDL here, and I think it's because the bone's so dense, you just don't expect much of it to diffuse through. Okay, maxillary posteriors. This is our molars. Look for those MB2s. Buccal infiltration with 2 carps is probably going to give me 45 minutes of solid pulpal anesthesia. High success rate, not super long lasting. Make sure you test with a cold test before you get going. And you can still use an intrapulpal or even an IO or a PDL down the road if you need it. And something to emphasize, it can be used all the time, but especially with maxillary posteriors, you're only going to get 45-ish minutes. So plan on giving an additional injection 45 minutes in. The patient won't always ask for it because the anesthesia will wear off slowly, but just plan on doing it, even if they're not saying that they feel it, to keep that pain below that threshold. They're going to have a better experience, and it slows you down a little bit, but it's worth doing. Especially, I'm slow enough at root canals that a maxillary molar is not getting done in 45 minutes. I'm going to need more time, so I know I'm going to need that additional injection. Maxillary anteriors, you're just going to do the local infiltration with articaine again. It's going to be even shorter acting for these, so plan on an additional one in about 30 minutes. Now some other brief points to go over. Preemptive NSAID use. If you give someone 600 milligrams of ibuprofen an hour before, your success rate for pulpal anesthesia increases. It makes the environment less acidic. It reduces the amount of pain channels that are being activated. It lowers their anxiety level. Overall, the effect is increasing the threshold of signals that have to make it through before they perceive it as pain. It's worth doing, really worth talking to your patient with this and helping them with this. It's easy to do, and it has a significant difference. Irreversible pulpitis patients are going to need more anesthetic. One study said 8 times more likely to have difficulty achieving pulpal anesthesia. Some teeth, particular mandibular posteriors, are just not going to get numb. They're going to need an IP. If you're doing an incision and drainage, don't inject into the lesion. Inject on both sides of the lesion and take it easy. It can be really painful, and the injection will fail if you give it into the lesion. If you have oral conscious sedation or nitrous oxide in your office, consider using it for the same reason as the NSAID use. It lowers anxiety. It really helps people make it through the appointment without having problems. And I really liked this last line is a quote from Cohen. Patient satisfaction may be related to bedside manner more than avoidance of pain. So remember compassion. Remember to be honest and upfront and explain to them you're doing your best and you're doing the best things for them. And that will matter more than if it hurt at all or not. Thanks for listening, everybody.